During this presentation, we will be discussing a client with spinal stenosis. This client had a laminectomy and a C3 to C7 spinal fusion, resulting in quadriplegia. This project was created by Miriam, Ashley, Austin, and Amanda. In this first part of the project, we are going to discuss the occupational evaluation. This is going to look at how well he is able to perform activities of daily living. For feeding and eating, he requires modified independence because he uses adaptive equipment. He requires setup and then supervision. Grooming will be assessed at the next visit. For upper body dressing and bathing, he is max assist. This is because of the limited range of motion, strength, and endurance in his upper extremities. For lower body dressings, he is mod assist. This was noted from the previous evaluation. And for lower body bathing, he is also max assist because he struggles with balance and strength. This will be a continuation of the occupational evaluation. For toileting, he needs max assist. For bed mobility, he needs moderate assist, as this was noted from the previous evaluation. From bed to chair and ambulation, he will need max assist. This will be because of the decreased strength, endurance, and balance. As far as assistive device management goes, he will need help with setup and max assistance. When looking at transferring to the toilet or to the tub, this will need to be further assessed at our next visit. Beyond basic ADLs, looking at objective information. As far as sensation goes, he has impaired sensation on both sides, but his left side seems to be worse than the right side. This will impact his ability to sense sharp versus dull or cold versus hot. Play skills were not assessed because it's not age appropriate. And then education participation was not assessed because of his current occupational roles as a doctor. And then other things to consider is that he got a spinal fusion of C3 to C7, which will have decreased range of motion for neck flexion, but also to engage in overhead IADLs.
When evaluating the client's shoulder, elbow, forearm, wrist, and digits, the active range of motion for the right and left sides was considered impaired as he had decreased range of motion during flexion and extension. His passive range of motion for all would have needed to be assessed at the next visit to determine end range. His manual muscle test showed impairments in the shoulder, elbow, forearm, wrist, and digits, with 2 out of 5 on the right side and 2- out of 5 on the left side, showing that his left side was more affected. The client had no visible swelling or edema, and it was noted in his previous evaluation that he had impaired sensation in both upper extremities. Regarding his grip and pinch strength, both the right and left were impaired. Muscle tone in the upper and lower extremities and the trunk and neck were considered hypertonic. The client presented with poor postural alignment as his decreased stability caused him to have a curved back. Coordination was determined to be impaired for both the right and left and for both gross and fine motor. The client needed constant verbal cues during sit to stand and ambulation to keep proper form. While the client never mentioned any pain, he became fatigued very easily during activities. Regarding the client's lower extremity, he was able to move volitionally with assistance, and we would refer him to PT to further work on this. He used a walker with assistance to ambulate with aid from an OT and PT. His static sitting balance was considered safe in a chair, while his dynamic sitting balance needed standby assistance. For both his static and dynamic standing balance, he needed moderate assistance. Both his sitting and standing balance were considered impaired for functional endurance. The client required glasses all the time, and his hearing was within functional limits. His communication was considered within functional limits, however, he could become hard to hear at times. The client was cooperative and alert during his therapy sessions and was oriented to person, place, time, and situation. The client had impaired perception due to decreased sensation in the upper extremity. He had difficulty sequencing complex movements in a timely manner. The client was able to maintain attention, regulate emotions, and was able to control his thoughts. He had a high level of cognition as he was able to perform tasks that required executive function. The client was consciously aware of the entire session and was A&O times 4, which showed that his orientation was intact. Sleep was not addressed during any of the treatment sessions. The client was completely verbal with communication and responsive, but his speech was slightly slurred. He was very literate and well educated, so it is not difficult to comprehend his speech. His social and emotional regulation skills need to be assessed at the next visit, and he handled his frustration with eating well and kept calm when he did not succeed at the task.
So for our treatment plan, we would like to assess a couple of different performance skills. These include things like ADLs, which requires skills with grip and manipulation, functional mobility, which requires navigation and alignment, sensitization, which requires touch, searching, and gathering. Fatigue and energy conservation as well require skills like pacing and accommodation. We would like to break this into 3 different short-term and long-term goals, with the first one stating that client will use built-up utensils to complete 75% of his meal with modified independence to show increased grip strength and endurance within 3 weeks. The long-term goal associated with that would be that client will use fine motor skills with modified independence to engage in self-care ADLs for his morning routine with 0 rest breaks by discharge. Going on to the next short-term goal, we stated that client will perform 5 sets of stands with no verbal cues with min assist within 3 weeks. The long-term goal associated with that will be that the client will use a walker to ambulate 75 feet with 1 rest break with modified independence by discharge. The last short-term goal we want to assess is that the client will demonstrate knowledge of 3 energy conservation techniques to decrease fatigue with ADLs within 1 week. The long-term goal associated with that is that the client will complete transfers from bed to wheelchair with contact guard assist in less than 3 minutes with 0 rest breaks by discharge. For our specific treatment plan, the next thing we want to address is targeting some of these goals in 2 separate interventions. Each intervention will last 1 hour each, with the first 30 minutes being more physically demanding activities. The second bit will be a 15-minute less demanding activity. And the last bit is going to be 15 minutes of working on transfers or mobility. So our first intervention is going to target long-term goal number 1, short-term goals number 1 and 3. The first 30 minutes is going to have the client using a reacher to pick clothes out of the drawer or closet, beginning to don a shirt with the affected side being the left side more so, and that side will go in first. So we'll be teaching adaptive techniques so that the next phase we can begin donning pants with the use of a dressing stick. Lastly, we can teach use of how to use a sock aid and shoe horn to don shoes and socks. The next 15 minutes of the intervention is going to involve using built-up handles to enhance fine motor skills with eating fruit or other foods like so. And then we will practice using a swivel spoon for thinner liquids and solids, like oatmeal. The last 15 minutes will have him practicing pursed lip breathing techniques to help decrease fatigue with transfers. Then he will use those techniques while performing 3 transfers from wheelchair to bed. So for the second intervention, we are going to break that up over long-term goals 2 and 3, as well as short-term goal 2. The first 30 minutes are going to include transfers from wheelchair to walker, and then using the walker to walk 20 feet, turn around, go back to 20 feet, sit down, take a rest, and repeat 3 trials. The next 15 minutes is going to include using a sit to stand position to position himself near a whiteboard. While standing, the patient will use an adapted marker to engage in a game of hangman. He will sit down for a rest break when it is not his turn and stand back up when it is. The next 15 minutes are going to include him transferring from a plinth to a wheelchair within the therapy gym. This will be incorporated on a daily basis to help build strength and endurance back up.
I'm going to be discussing how you can grade up and grade down dressing, fine motor tasks, and transfers. So grading up a task means making it more challenging. So for dressing, you could remove adaptive equipment such as a shoehorn, a dressing stick, and a sock aid, and this would allow the individual to complete the task independently. For fine motor, you could also remove the adaptive equipment such as built-up handles and require the individual to use regular utensils. You could also require the individual to complete the feeding task independently without zero assistance. And for transfers, to make it more challenging, you could always time the individual and try and have them complete the transfer in a certain amount of time instead of allowing them to do it within their own pace. For grading down or making tasks easier, for dressing, you could have the individual wear more comfortable clothes that are easier to put on, such as baggy t-shirts, sweatpants, or basketball shorts. You could also place the individual's clothes next to them instead of having them pick out the clothes themselves, which usually requires more effort. For fine motor, you could have the individual use protective orthotics such as a dynamic outrigger to keep the hand in a functional position. And for transfers, you could increase the amount of assistance that the OT provides the individual, which requires the individual to exert less energy. The occupational adaptation frame of reference could be applied to each treatment session because we are incorporating different devices and techniques to allow the patient to engage in occupational activities. Several CPT codes could be applied, such as therapeutic activities, because we're working on activities to improve fine motor skills and transfers. And the AEDL CPT code could also be applied because we're working on dressing. Next, I'm going to be discussing potential factors that could impact therapy and make a few suggestions on modifications or adaptations that can be applied. So for fatigue, you could incorporate rest breaks and energy conservation techniques such as pursed-lip breathing. For weakness, you could incorporate upper extremity ADLs and weight bearing activities to help increase strength. For cognition and memory, although our patient has intact cognition and memory, you could still address cognition if it was impaired by using like a visual schedule in their room to help improve memory. For pain, both physical or emotional breathing techniques such as the pursed-lip breathing that I mentioned could be used to help calm them down. Biofeedback could be used, TENS unit, and massage can help address pain. For tremors or ataxia, you could use weighted utensils or wrist weights. Dysphagia, you could thicken the individual's liquids during meal times. For fine motor deficits, you could incorporate built-up handles or other devices that allow gripping and pinching to be a little bit easier for them. For a fall risk or poor balance, you could remove rugs or objects that are on the floor that could increase the risk of tripping. And you could also incorporate handles or supports throughout their home. Our patient does not report any sleep disturbances, but some individuals may benefit from calming music if they do report issues with sleeping. Difficult behaviors could be addressed. Although the patient's cognition appears to be fully intact, and he doesn't have any symptoms of disinhibition or extreme mood fluctuations, some individuals do have difficult behaviors, for instance, as getting frustrated or being angry. Our patient seems to keep himself pretty calm and collected and doesn't show any reactions as those stated during his ADLs. However, taking rest breaks and grading the activity down with repeated unsuccessful attempts can combat difficult behaviors due to frustration. And for vision and visual perceptual changes, it's unclear whether or not our patient, if his glasses were prescription due to the compression of the spinal nerves or if it was due to some other visual acuity deficits prior to. And the quarterly Snellen's test could be used to determine if there's a progression in deficits.